Opioids. Introduction. The plant may have been used as much as 6,000 years ago, and there are accounts of its usage in the ancient Egyptian, Greek, Chinese, and Roman documents. In the 18th century, the main active ingredient morphine was isolated by Schirmer, a famous German pharmacist who proposed the name morphine for the compound after Morpheus, the Greek god of dreams. Opium is obtained from the opium poppy, the plant Papaver somniferum. Opium is isolated from the opium poppy by making an incision in the seed pod after the petals of the flowers have dropped. The white latex that oozes out turns brown on air and hardens on standing. This sticky brown gum is opium. Opium, in fact, contains about 20 different alkaloids, including morphine, codeine, terpene, and papaverine.
Pharmacotoxicity, pharmacokinetics. The absorption of opioids are well absorbed from mucous membrane GIT as well as parenterally. For the most intravenous route is the most potent metabolism and biotransformation. Compounds with hydroxyl group like morphine are conjugated with the glucuronic acid of the liver. Esters like heroin are hydrolyzed by the common tissue esters like acetylcholine esterase. Another minor pathway is the hepatic N-demethylation, which ends in formation of monoacetylmorphine, the active ingredient that will be detected in urine tests.
Excretion, mainly renal, and the metabolites can be detected in the urine as we mentioned before in the form of monoacetylmorphine. Small amount is excreted in the bile. The second point to be discussed under this title is the pharmacodynamics. What is the action of morphine or opioids and how it do its action? Pharmacodynamics. Action opiates produce their effects via binding specific opiate receptors, which in fact are protein structures that are present in the CNS of many other tissues with higher concentration in the limbic system, thalamus and hypothalamus, midbrain, and spinal cord. Why these receptors are normally present? These receptors appear to be the normal site of action of several endogenous polypeptides having opioid properties, including enkephalins, endorphins, and dynorphins. The types and effects of opiate receptors are many. For you, as undergraduate, they include mu receptors, which is stimulation responsible for supraspinal analgesia, respiratory depression, euphoria, and physical dependence. The receptor number 2 is delta receptors, which is stimulation responsible for modulation of mu receptors activity as well as affective behavioral involvement. The third type of receptors is kappa receptors, which is stimulation results in spinal analgesia, sedation, and meiosis. In the past, sigma receptors was considered a type of opiate receptors, and its stimulation results in or responsible for vasomotor stimulation, respiratory stimulation, mydriasis, dysphoria, and hallucinations. We observed that the effects of the stimulation of this receptor is the opposite of the other receptors. Moreover, it is not blocked by the antagonists. So recently it is excluded and have not been a receptor of opiates yet. Medical uses. Opioids are used in medical fields for many indications. The first is analgesia. It's used in severe constant pain refractory to other non-opiate analgesic, like cancer, terminal illness, obstetric labor, acute myocardial infarction, which here is a life-saving measure Moreover, it is used in renal colic, severe biliary colic, and massive bone fractures like in accidents. The second indication is acute pulmonary edema. It has been found that opioids are effective in such condition, especially if associated with left ventricular failure. The exact mechanism is unclear, but it may be improved. It may be due to the improvement of the condition by sedation and anxiolytic effect, relieving dyspnea secondary to diminished anxiety and decreased peripheral resistance. Third indication is cough. It is not used as antitussive measures nowadays, but codeine is still used in many antitussive therapies like codifan and codeine. The fourth indication is diarrhea. It is not used nowadays, but more specific opioids are used with higher selectivity for the GIT movement. These in the form of diphenxylate drug like motinorm, motilium, gastric, etc. Anesthesia. It was used as a pre-anesthetic medication to shorten the induction period via its sedative, anxiolytic, and analgesic effect. But its usage is obsolete as it causes respiratory depression, meiosis, which interfere with the pupillary signs of anesthesia, depression of the intestinal motility, which may end in paralytic ileus, vomiting, and urine retention. Recently, it regains its usage as in cardiovascular surgery with respiratory assistance and in regional anesthesia as epidural anesthesia. The sixth indication is the treatment of morphine or other opiate addiction by substitution. However, more recent drugs are used instead. The seventh or the last indication for you is the treatment of shock and internal hemorrhage. The mechanism of action in such condition is unclear. Mode of poisoning. Accidental cause is the commonest cause of opiate poisoning. However, it can be doctor-induced due to clinical overdosage. Suicidal is not common, but reported especially among persons can obtain such chemicals like doctors, pharmacists, and chemists. Homicidal. It is so rare condition, but recently a serious phenomenon was aroused in the Western countries where group of doctors collected together or gathered together and intend to terminate their patients of the terminal illness according to their patients' will, just to relieve this pain. This is not accepted legally or religiously. This phenomena was aroused in the 2000s by the Dr. Harold, an English physician, which was accused by killing 339 of his patients using morphine. Fatal dose. The crude opium fatal dose is about 2 grams. However, 100 milligrams of morphine may be fatal. For 50% of the experimental animal, fatal dose is an experimental measure, not for human. However, addicts can tolerate as 10 times as fatal dose for normal people, while children are highly susceptible to fatalities with much less doses than usual. The fatal period of opiates are expected within the first 6 to 12 hours. However, many times this occurs within few minutes in cases of massive administration. Clinical presentation. Stimulation of the opioid receptors, leading to stimulation of some functions and depression of others. Opioid stimulates chemoreceptor trigger zone, which is the vomiting center, so the patient is vomiting even when comatose. Second, opioids stimulate vagus, which in turn leading to hypotension and bradycardia. Stimulation of the oculomotor center with pinpointed early active pupil to light. More and more it stimulates the euphoria. Thus, the addicts take these materials to induce this euphoria. On the other hand, opioids depress respiration by depression of the respiratory center, depression of cough centrally, depression of pain perception centrally, and depression of the cortex with loss of consciousness and coma. Thus, the clinical presentation is expected to be in the form of early neuropsychiatric manifestation, in the form of euphoria, relief of distress, and pain. Then dysphoria, restlessness, and anxiety and fear of death. Finally, there are gradual drowsiness, sleep, and coma. Actually, you will never see the patient in the first or early manifestation. The patient will never come to the ED for euphoria or relief of distress and pain. He will actually come in coma, which has characteristic features. It has slow tortuous respiration, slow pounding for regular pulse early, then later will be bradycardia and irregular weak pulse. There is bilateral symmetrical pinpointed reactive pupils to light, subnormal temperature or hypothermia, moist skin and cyanosis peripherally and centrally, vomiting even when the patient is in coma. Terminally, there is irregular respiration in the form of Keynes-Stokes respiration, which is a mode of respiration characterized by alternative periods of apnea and hyperventilation. There is deep cyanosis, circulatory collapse, dilated reactive pupil, and death in central respiratory failure. Treatment. Like any other intoxicated patients or cases, the treatment will include three lines. Number one, the general measures. The number two is the specific measures. Number three is the symptomatic and supportive measures. The general measures here includes emesis using syrup of ericac, gastric lavage is carried out using tap water, or one of the common alkaloidal antidotes. The third step is serial administration of activated charcoal or gut dialysis. Then application of cold fomentation and tourniquet at the site of injection. It is taken if the drug is taken parenterally. Specific measures. Specific measures mean the antidote. Fortunately, there is specific antidote of opioids. In the acute cases, naloxone is the best. It is the drug of choice for acutely intoxicated patients. It is the physiological antidote, that's to say it is a pure antagonist at the receptor sites. It is given in 0.1-0.4 milligram intravenous bolus. This could be repeated several times without ceiling level. Sky is the ceiling. It is to be mentioned that nalorphine is not indicated nowadays, as it has been proved that this agent is a partial agonist-antagonist drug. The third line is symptomatic and supportive measures. In the form of respiratory support, it is the first step in treating such cases, including establishment of patient patent airway by intubation, positive pressure artificial respiration, repeated suction of the bronchial secretions. Respiratory stimulants are absolutely contraindicated nowadays. The step 2 is care of comatose patients. 3. To keep the body warm by blankets. Treatment of shock if present. Opiate antagonists. The most widely used pure opiate antagonists in practical toxicology are naloxone, Narcan, and naltrexone, Trexan. These drugs are morphine derivatives with larger substitution at the N position. Pharmacotoxicity. Pharmacodynamics and kinetics of these drugs have to be known. Pharmacokinetics easily, naloxone is poorly absorbed after oral administration, so it must be given parenterally. It has a short duration of action from 1 to 4 hours, so it must be repeated. Metabolism is mainly hepatic by conjugation, so it is to be considered the liver condition in giving this drug. Naltrexone will absorb it after oral administration, so it is given orally. It has long duration of action up to 2 days, so it is given for long-term program for addiction. Metabolism mainly hepatic, and there is first pass mechanism or metabolism. Pharmacodynamics, mechanism of action. These are pure antagonists to all opiate receptors with much higher affinity to mu receptors than the other receptor types. It is 20 times than kappa receptors. The therapeutic effects of naloxone, it depends on the condition of the user. It is many different points in the different persons. When given to normal person has no effect, it is inert material. When given to an addict, the abstinence syndrome will be present. When given to acutely intoxicated persons, there is reverse completely the effects of opiates within 1 to 2 minutes. This represents one of the most dramatic antagonists in medicine. It is a magic drug in medicine. It normalizes respiration, level of consciousness, size of the pupil, and even bowel motility within 2 minutes. Medical uses. Naloxone. It is used in acute opiate intoxication. It is the major medical application of this drug. Diagnosis of opiate addiction. It is what is called naloxone test. It is given in clonidine toxicity, which is antihypertensive drug. Reversal of ethanol coma. It is doubtful effect. Treatment of shock. The exact mechanism here is unclear. It is given in cerebrovascular strokes. It promotes limitation of the infarct area by a known mechanism. It is one of the standard drugs of coma of unknown etiology. On the other hand, naltrexone is given in opiate addiction. It is used in a long-term program for the major application of this drug. It is given also in the cerebrovascular strokes like naloxone. It promotes limitation of infarct area by a known mechanism. Thank you.